Ooh, I hate it when Mark Cuban's right. I don't always agree with Mr. Cuban, but he's on point here. The American healthcare system is ripping people off left and right, and everyone in Washington knows it. We're getting ripped off legally.
My Shark Tank companies hate selling on Amazon, but most don't have a choice. About 162 million Americans shop there, and if you want to reach them, you have to play by Amazon's rules. Amazon knows this and takes full advantage, adding and raising fees, and even launching competitive knockoffs. They get away with it because they control the marketplace and because 162 million people shop there, which makes Amazon incredibly sticky. So what does that have to do with healthcare? Insurance companies work the same way. Over 300 million Americans have some kind of coverage: commercial, ACA, Medicare, or Medicaid. Every one of those plans hires a pharmacy benefit manager, or PBM, to run their drug benefits. The biggest PBMs, all owned by the largest insurance companies, control pharmacy benefits for about 270 million Americans. That's a lot of power. And that's also 70% more people than Amazon reaches. Like Amazon, PBMs control the store shelves, but their shelves are called formularies. The list of drugs your insurance will cover, and if a drug isn't on the formulary, it's invisible to doctors and patients. But here's the kicker. Unlike Amazon, which wants lower prices, PBMs actually prefer higher prices. They say they negotiate lower drug costs, but they don't. They auction off access to their formularies to the highest bidders. Drug companies pay the rebates and fees PBMs demand so their drugs can be covered and prescribed. If they don't pay, they lose access to millions of patients and plenty of doctors, costing them billions. These rebates and fees are based on a percentage of a drug's list price called WAC, the wholesale acquisition cost. The higher the list price, the more money PBMs make. Because PBMs are so powerful, that inflated list price becomes the reference point for the entire drug supply chain. Take a hypothetical $600 brand name drug. The PBM strongly suggests the manufacturer set the price at $600, with a 50% rebate and another 10% in fees, leaving the manufacturer with $240 net. Meanwhile, wholesalers buy the drug at that same $600 list price. How many industries do you know where the wholesalers pay the full list price? The three major wholesalers all use the same list price and get paid almost identical fees. There's zero competition, and their fees are also, because they're tied to list price, they make more money when prices rise. Pharmacies buy from wholesalers at about a 5% discount. You'd think PBMs would reimburse them more than their costs so they can make a profit. They don't. When a pharmacy fills a brand prescription for an insured patient, it's often reimbursed less than what it paid for it. And if it doesn't fill enough of those money-losing prescriptions, PBMs or wholesalers can penalize them. It's no wonder independent pharmacies are disappearing. Now, what does the patient pay? If they're uninsured, they pay that $600 list price. If they're insured but haven't met their deductible, they still pay the full $600. That's crazy. We were told that PBMs negotiate lower prices for patients, but they're so bad at their jobs, they can't even get patients a deal that's better than the retail price. But the rebates and fees that they collect on that $600 flow straight from the patient's pocket to theirs. Patients are getting ripped off because PBMs and wholesalers insist on using inflated list prices instead of transparent net prices. Because the whole system is built around list prices, everyone, PBMs, wholesalers, and insurers, have an incentive to keep prices rising, and they almost always do. It's costing patients tens of billions of dollars and forcing many to go without the medications they need. But here's the saddest part. Self-insured employers, states, the federal government, they all keep on signing contracts that lock in this broken system. We blame PBMs, but the real problem is the CEOs, administrators, and state officials who keep renewing these contracts. Every one of them complains about rising healthcare costs while signing deals that make prices go up. Big brand pharma is part of the problem too. They hate PBMs, but still play along. If manufacturers, wholesalers, and payers move to net pricing, meaning the price after all rebate and fees, patients' out-of-pocket costs could drop by half overnight, saving patients billions every year. There's a reason the US has the highest drug prices in the world. We're the only country that uses PBMs. And there's a reason we have some of the lowest priced generics. PBMs can't control generic pricing from companies like Cost Plus Drugs. So what do? 1, count all cash payments towards deductibles. 2, base patient out-of-pocket costs on net price, not list price. 3, separate formularies from PBMs to end their power. And 4, and specialty tiers. It's just an excuse to charge more. Fix that, and we finally put patients, not PBMs, back at the center of American healthcare. Thank you.
Mr. Cuban, innovative companies like Cost Plus Drugs have already proven that bypassing traditional PBMs can deliver real savings at pharmacy counters. President Trump has announced Trump RX, a new website to connect patients directly with the best prices. How might Trump and RX and direct patient programs improve affordability for patients? Your basic, why you're doing this.
Yeah, I mean, we'll work with Trump RX. I mean, it's incredible. It's stupendous. It's like the most incredible program ever. And so we're excited to offer them our API so that they'll be able to download our daily prices. So when they go down, everybody benefits. Plus, I like what they're doing with the MFNs because, as I mentioned in my comments, our brand drugs are more expensive because PBMs are involved. And with Trump RX and the MFN program, that allows manufacturers to work around the PBMs and work directly to patients. So I think it'll save seniors, it'll save everybody a lot of money.
You think this is the future?
I don't think it solves the ultimate problem of how the system is designed, but I think it's something that we obviously agree on because that's what Cost Plus Drugs is. We publish our entire price list every day.
Your company posts drug prices with full cost breakdowns. How does this transparency help save patients money?
I mean, you know, with costplusdrugs.com, any patient can just go look at their price for their medication. And so there's no uncertainty. But more importantly, by seeing our markup of only 15% and seeing our costs, that builds trust. I always tell everybody in our company that what we really sell in this industry is trust. And so I think that's what's really allowed us to grow so quickly.
So if you sold Ozempic and somebody else went through PBMs, how much cost would they save?
Well, if you look at what's happening now where the PBMs work with sponsors, they're typically being charged $1,300. And if you look at the direct-to-consumer programs that are being put out there by Novo and Lilly, it's $499 or less and probably falling. So there's already a significant difference. And the crazy part is that difference of $800 typically goes right into the pocket of the PBM, who then decides how much they're going to give to the employer. So it's a huge amount as of right now.
Thank you.
Mr. Cuban, can you speak to this conversation about unaffordable deductibles? Can you talk a little bit about what this will result in, whether it's increased hospital visits, emergency room visits? What does this vicious cycle of unaffordable health care costs lead to, and how does it stress the healthcare system?
Well, no matter what your premiums are, and you pay them, if you can't afford your deductible, you don't really have insurance. And what ends up happening is either you go to the emergency room, you do nothing at all, or you're at the mercy of the provider, hoping they can provide some sort of financing for you. Either way, it creates very difficult situations for seniors, for entrepreneurs, for anybody in that situation. And as I alluded to in my comments, we don't do anything to help people who are unable to afford their deductibles. And in fact, we make it more difficult. Dr. Smith alluded to the fact that, the cost of a surgery could be extremely high. And if you can't afford your deductible, you can't get it. In the case of pharmacy benefits, if you have a drug like Eliquis where the list price is $600 and you have a $4,500 deductible under an ACA Silver plan, you're going 7 months having to pay full list price. And if you can't afford to do that, you're out of luck.
Right.
So military families keep us safe, and DoD's TRICARE program is supposed to keep those military families healthy. Since 2009, the TRICARE pharmacy benefit has been administered by Express Scripts, the nation's largest pharmacy benefit manager, or PBM. Express Scripts decides which pharmacies are in-network or out. So when one of those 9 million military families needs to pick up a prescription, Express Scripts decides where they can go to have it filled, and then they pay the pharmacy. Now, Express Scripts is owned by the multi-billion-dollar health insurance company Cigna, and Cigna also owns a mail-order pharmacy called Accredo that participates in TRICARE. In other words, Cigna owns the company that pays the pharmacies, and it also owns the pharmacy chain that is getting paid. The result? Well, Express Scripts can under-reimburse the other pharmacies and give inflated payments to its corporate cousin, Accredo. Express Scripts has been caught doing exactly that kind of self-dealing in other government programs, but right now the Department of Defense refuses to check how much it is costing taxpayers in TRICARE. Mr. Cuban, you understand this business, so let me ask you, would requiring Express Scripts to disclose the difference between what it pays its affiliated pharmacies and the unaffiliated pharmacies help save taxpayers money or cost taxpayers money?
It would save a lot of money, and it would keep smaller independent pharmacies in business.
Okay, that makes sense to me. It seems pretty common sense here. More transparency would save taxpayer money. But the Congressional Budget Office disagrees with you and me on this. According to the CBO, price transparency would cost taxpayers money because other pharmacies would allegedly band together to demand higher reimbursements. That's their argument here. Mr. Cuban, you talk with pharmacists a lot. Do you think that independent pharmacists don't know that Accredo right now is getting a sweetheart deal and that the independents are just waiting for information to be told so that they could demand more money?
I can't speak for all the independents, but I can speak for costplusdrugs.com. And so I went to TRICARE, and I have done this in the past many times, and looked up the price of some common low-cost drugs. So just recently I looked up Tadalafil, right? And our price is lower, whether it's 30 or 90 pills, than the TRICARE price is for anybody who is in network but off base. And if they're out of network, we're dramatically lower. So we don't need to band together to know that we can be cheaper. All we have to do is look at some of their prices, and it's obvious that we're cheaper.
Okay, so this information is actually already out there.
Yeah, I mean, it's just by looking at, and I'm just talking about the copays.
Yeah.
We're not even talking about what the taxpayers still have to pay to Express Scripts, Accredo, right? Which is more. They're not doing this for nothing. And so, I mean, taxpayers are getting ripped off, period, end of story.
Okay, and this is where I want to see more transparency.
Correct.
You think that's a good thing?
That's a great thing.
Oh, okay, that's a great thing. Good, I'll settle for that answer.
I've just got a very quick couple of questions. But in a state like ours, Mr. Cuban, many people rely on independent pharmacies. What kind of pressures are the PBMs putting on these pharmacies?
It's horrific. So I mentioned in my testimony that, first of all, the wholesalers buy drugs at the list price, and then they sell to the pharmacies at just under the list price, which means those independent pharmacies, small businesses, are out a lot of money. So for instance, on an Eliquis $600 point price, they're out $570. And they need to collect that money back as soon as possible. What PBMs do is not only wait to get the value of the float, but they also under-reimburse them. So instead of paying them at least the $570 so they can break even, they pay them less, knowing that there's only so much they can take where they'll either A, go out of business, or B, send the prescription to one of their captive pharmacies. And that in turn means they're not supporting their patients. And let me tell you something that a lot of people don't appreciate. That last 5 feet between the patient and the pharmacist is some of the most important time any patient will ever spend, because if they're getting medications that conflict with each other, then some really bad things can happen. So we underappreciate pharmacies, and the big PBMs are literally purposely, as far as I can tell, putting them out of business.
Mr. Cuban, you could talk about the pharmacy industry, how PBMs hide it, or you could just talk generally about healthcare, what the impact of a price tax bill would do, do you think?
It would be great. I mean, for my companies, we're already starting the process of direct contracting. And the only way you can direct contract is if you know the prices. And by knowing the prices, we can make our own determinations about what our cost of care would be, because once we have our claims, we can look at our historical claims and kind of extrapolate to see where they're going. But point two to that is it would crush the big insurance companies, because it allows us, and this is what we're doing, to A, direct contract with providers, and B, just work with a third-party administrator to handle all the services and just figure out the care navigation with a third party as well. They're really, it's rare that insurance companies take all the insurance risk these days. And so this is just one more way to accelerate the move from them towards companies in particular, taking responsibility for all their own care.
So my belief is whatever we can do to turn patients into consumers again is going to help bring the cost of healthcare down. And if you want to be a consumer, you have to know the prices as well. Mr. Cuban, you want to talk a little bit just about the opaqueness of PBMs, the traditional PBMs, that how they truly are hiding the cost from my mom and dad when they go to their local pharmacist.
Cost Plus has been in business 3.5 years, and we're still the only pharmacy that publishes their entire price list. As Mr. Moles mentioned, he used us as a reference price. When the FTC investigated the PBMs, they used Cost Plus Drugs price list as a reference price. And so they're doing all they can to prevent transparency. They also do the same thing with contracts. Anytime you have a contract with an employer in particular, or state or federal government, they always put in there may be other fees that we charge you, right? And then they'll play games like with rebate GPOs. What a rebate GPO is, you would think a PBM is big enough to just negotiate with the brand manufacturers and get the best rebates they can. But that's not what they do. They create these intermediary subsidiaries called rebate GPOs that in turn go and negotiate with the brand manufacturers, let's in any given example, 60% in rebates, give back 40% to the actual PBM, who in turn goes to the plan sponsor and says, here's the whole 40%, not disclosing that they kept 20% through their rebate GPO. So those are the types of things, and there's a long list more. But I will say, the one thing for every employer or anybody listening is if you're paying any fees as a percentage of a price of a drug, you're getting ripped off.
Some studies show that healthcare consolidation also leads to increased healthcare costs. So to any of you who want to talk about this, to what extent do you agree with these findings? And could you please describe your experiences with healthcare consolidation and its increase in healthcare costs, starting with Mr. Cuban?
I mean, I don't have anything specific to add to that other than our own experiences, that when a PBM owns a pharmacy, when an insurance company has an investment in 10% of the doctors out there, they are going to optimize for their top line.
Right.
And I can tell you that when you look at the biggest insurance companies, they have 2,500 plus subsidiaries. The intercompany transfers for just one of them alone is equal to 0.3% of the USA GDP. So you know that they're gaming the system in every way they can. And if you disintermediate them so that, or separate them, you'll see prices fall because they won't be able to arbitrage the financial system.
Mr. Cuban, how does the level of transparency, you're cost plus, right? You know your prices, and then your costs, you add 15%, right? And you just tell everybody, so everybody knows. So how's that changed behavior? How's that changed, what have you watched how it changed behavior?
I mean, I look to see people start shopping more, to answer your question directly, because now they know when they go to the pharmacy counter and they're shocked by a price, and we get emails and calls and letters all the time. I thought this medication was going to cost me $900. I went to Cost Plus and it was $21. And then they tell people, Cost Plus is growing and we don't spend a penny on advertising. And the reason is when you save somebody money on their health care and their medications, they're going to tell everybody.
Right. So how many employees you have at Cost Plus?
70, maybe, and that includes manufacturing.
Okay. All right. And so how do you structure your health plan?
Our own health plan. So we created something called Cost Plus Wellness, where we're going and we're doing direct contracting with providers around Texas and where we have employees. And I met with a lot of CEOs and CFOs of hospitals and found out where the insurance companies were taking advantage of them. They underpay their contracted rate with high deductibles. You turn the hospital into a subprime lender, right, with the delays from the pre-authorizations. So we said, we'll do none of those things. If you give us a better reference price, we'll pay you cash up front, no deductibles, and no pre-authorization. So we're able to get a much better price. And what we're going to do that's different, by the end of the year, we'll have costpluswellness.com, where we're going to publish all our actual contracts. Because when we talk about transparency, it's one thing to talk about prices, but most companies don't have the sophistication to understand the contractual details. So we'll publish them for anybody to copy. And then for our employees, they have no out-of-pocket when we work within the system. And for our employees, for any drugs from Cost Plus Drugs, they have no out-of-pocket as well.
So if they go outside the system, what happens?
So if it's for healthcare, someone's in a car accident somewhere, then we have kind of a healthcare navigator, what we call our healthcare CEO, that will call the hospital and say, hey, we'd like the cash price. Because part of the craziness of this healthcare industry is, the biggest insurance companies will negotiate a $25,000 rate for a hip replacement, and any Tom, Dick, or Harry walking in off the street can probably get it for 15. And so we'll negotiate directly to get the better price.
So do your employees have any costs at all in healthcare?
Yeah, in some of them, yeah, depending on which one of the companies they're in, they do, but for the Mark Cuban companies directly, they do not.
Okay. And so when you do, why do you have them have any skin in the game?
Why don't we? Because
No, why do they have do they have any charge at all? Why do the employees have any charge at all? What's the rationale for that?
on the side that does have, I mean, it's really just because as a startup, we're progressing through all this. The goal is to get them so they don't have any responsibility, because we want to use it to retain them. Now, I get where you're going with your question. You want smart shoppers going out there to be able to make the best decisions. But we'll have a healthcare CEO, CFO, who goes out there and does the negotiating for them.
So they won't have a choice.
Well, they'll have a choice. I mean, they'll have the opportunity, but if it's not going to cost them anything, nobody complains.
Right.
Right,
So-
because what we're saying is, like, if you have a favorite doctor that you've always used and we're switching for whatever reason, we'll go to that doctor and say, hey, we'd like to do a direct contract with you. Here's, what will you charge us?
What if they say no, and I'm not going to do
Then
that?
we'll pay their going rate because we want our employees to be happy.
Mr. Cuban, so you know who's on your health plan, right? It does take Cost Plus. You know who's on your health plan, right?
I have a bunch of different companies, but generally.
But the CEO of the company would know who's on the plan, right?
Not necessarily, no.
They would know who's.
I mean,
covered.
generally, yes, but I've got a lot of different companies, so I couldn't.
Okay. So, but would you be okay if there was just an agent that could just sign up somebody and you paid 100% of it?
No, of course not.
Okay. So would it surprise you that in the COVID, what Senator Warnock was talking about, that the way it works is an agent can sign anybody up they want as long as they know their name, address, and birth date. And then the money goes directly to the insurance company. So does that sort of make sense to you?
Of course not.
Okay. Do you think there might be fraud, that people would take advantage of it?
I think salespeople are going to find ways to make money, aren't they, no matter what?
Mr. Cuban, do you think you could apply the same principle to some other areas of healthcare? Could we do it with MRIs and
Of
CT
course.
scans?
Yeah, particularly with those, because it's just equipment and some technicians and, some qualified doctors.
So have you worked with the Department of War? Are they contracting with you?
No.
Why not?
I have no idea.
Have you talked to them?
Have not talked directly, but when the DOD went out for one of their bids, the requirement was that thick, and it just wasn't worth the time.
Okay. So how about, and the same for the VA, and same for TRICARE?
Yeah, same.
So what Senator Warner was saying that you were checking the price. I think you said something. So how'd you find that? You were able to look at the TRICARE book.
Yeah,
and you could see what their price was.
And actually just their copays. We were cheaper than their copays.
And so, why would you be cheaper than our copays?
Because they're stealing.
Have they? I mean, is there?
Makes no sense, does it?
Can they?
There's a reason why they don't publish their price lists. And to Dr. Mold's point, prices vary by customer to customer to customer. And that's how they maximize their margins. And that's how they're able to control. Dr. Molto was smart enough to get a carve out from his PBM. Most companies are not big enough or able to do that. And so the PBMs will require that you buy from their pharmacy, that you buy from, specialty. The fact that there's a specialty tier for generic drugs or any drug, every drug is special in its own way. If you're being offered a specialty tier, you're being ripped off.
Have you been able to get into any employers that way?
There's more and more carve-outs now for GLP-1s because one PBM sold their access to the formulary and excluded another GLP-1. So some of those large customers are able to get carve-outs for GLP-1 specifically. But typically, we'll get those big companies to start working with transparent PBMs that include us in their network.
Is there something that the PBMs are doing that you can't do?
No.
Okay.
I mean, let me qualify that. We don't have access to all brand drugs. And what we're told from the brand manufacturers is the reason they don't sell to us is because it's been intimated to them from the big PBMs that if they do work with us, they will see their portfolios diminished on their formularies. Formularies give the big PBMs 100% of their power. If they didn't have control of formularies, and look, there's no specific skill set that they have that the state of California couldn't recreate for creating their own formularies, right? They just go out and negotiate that formula and effectively auction off access to that formulary. If you disaggregated by law formularies from PBMs, companies, patients would have better experiences because they would be more dependent on their doctors, and the entire rebate system would collapse like that. And when the entire rebate and fees system collapsed, the price of medications would fall, depending on the medication, 30 to 80%. And so their control of formularies gives them every bit of leverage.
So why do you think PBMs were started?
Why were they started? Yeah, back in the day, it was about negotiating pricing, and that's what they did. But they don't negotiate prices today. If they negotiated prices, they would just publish a price list. Hey, and I wouldn't be in business, right? Because they're big. They should be able to buy for a lot less than we can. But they don't negotiate prices. What they negotiate is, what they auction off is access to their formulary. And you see that a big part of the problem as a result is going back to when we talked about deductibles, right? All the stuff about the ACA. Well, you would think a PBM, if they truly were about negotiating prices to the benefit of patients, they wouldn't make patients pay full list price for a medication until they hit their deductible. But what happens when that insured patient has that $2,500 deductible and it's a $400 medication, out of the $400, let's just say $200 of it goes right to the PBM's pocket.
Mr. Cuban, you're starting to produce sterile injectables. Was that an easy process? Was the government really a good partner and helped you get that done?
No, it wasn't an easy process. And if I can add one more thing on the cost for Medicare and Medicaid, there have been multiple studies that showed if Medicare bought, I think it was oncology drugs through cost plus drugs, it would save $6 billion a year, $1 billion a year for urology drugs. But to go back to your question on our manufacturing facility, we had to work with the FDA, and it was slow, but it was efficient, and we were able to get it done. And honestly, now, since the change in administration, we're extending that, and they've been very good to work with and much quicker.
So are you like 3 times, 4 times, 5 times the international inject? If same thing, are your costs way higher than if you did this in Vietnam or India or China?
No, because we're mostly robotic. We're all robotic, and I'd say we're really close to being as cheap, if not cheaper, than overseas.
Right. So, do you? By the way, do you tell people where drugs are made?
I'm sorry?
Do you tell?
Where the source country is? Yeah, we don't at this point in time. It's something we're discussing. We have 1 drug that's made in China that might move to 2. We have a bunch that are made in India, but we check and we do batch checking and all that, and we're increasing the number that we get done here. Part of the challenge we have is the big wholesalers have these contracts with American manufacturers, and I forget the term, but it's like either deliver or your SOL, and that really makes things a lot difficult for us when it comes to for them to be able to compete with pricing.
So what do you think your prices And especially as you build up more volume, what do you think your prices are going to be on injectables versus something?
Well, they're already cheaper than anywhere else, right? And in terms of competitive with international, we should be less expensive. And we're changing how we do it. We've created these mobile pods so that we'll be able to not only make sterile injectables, but we'll be able to make N of one cell and gene therapy. So we can park one of these mobile pods outside a hospital. And when they're doing all kinds of genetic, my partner Alex over here knows this stuff better than I do, but when they're doing N of one analysis, we'll be able to convert it to a biologic that they can use with a child, and it'll cost a tenth of what it currently costs.
Do you think you could open up generic drug manufacturing at the same price as India and China?
Yes.
Okay.
Now, we might not have the scale initially.
Yeah, but once you get to scale.
Yeah, but I mean, it's
If you were doing-
robotics. It's all
If you were
robotics.
doing 1 billion pills a year, you think you can get there?
Yeah.